So good morning, everyone. So the next topic will be pulmonary embolism management in ED. So some of the terms, venous thromboembolism is a disease encompassing the DVT, the deep vein thrombosis, and pulmonary embolism, PE. So when DVT occurs, the thrombosis occurs and produce blood clots, which is the emboli, and now occlude the pulmonary arteries, and now it is called pulmonary embolism. So the infamous Verkhov's triad, the three things: hypercoagulability, circulatory stasis, and also the vascular damage. So for each of the criteria, you can also detect the risk factors for patients. So for example, hypercoagulability, any major surgery, malignancy, pregnancy, infection, sepsis, inflammatory bowel disease, estrogen therapy, inflammation, and dehydration can cause hypercoagulability. And next, the circulatory stasis, any immobility, varicose veins, atrial fibrillation, congenital abnormalities, and others lah. For the next one, vascular damage, any trauma, physical trauma, microtrauma to vessel wall.
Sorry, your slide is not moving there.
This is the three lah: hypercoagulability, circulatory stasis, and vascular damage. So we can also divide the risk factors into three, which is inherited, acquired, and transient. So for inherited, there will be antithrombin deficiency, basically the antithrombin 3 deficiency, which will affect the coagulation cascade. Protein C and S deficiency also will affect the activated factors 5 and 8, which will affect the coagulation cascade also, and cause pulmonary embolism. Next, acquired, the age, malignancy, antiphospholipid antibodies, which will interact with phospholipid protein, phospholipid bound protein, and activate coagulation, and also previous history of VTE. Transient risk factors, any surgery, pregnancy, OTP, hormone replacement therapy, prolonged immobilization, heart failure, MI, nephrotic syndrome, and also dehydration will cause is one of the some of the risk factors for pulmonary embolism. So the symptoms that patient
Farah,
represent.
sorry, Farah.
Yep.
We have a current issue. What I mean is, like, there's one risk factor at the moment. The whole Malaysia is facing now, which can it's one of the main factors to PE lah, which is
COVID.
Vaccine related, COVID related ke Doctor?
COVID, yes, COVID related pulmonary embolism. So especially post-COVID patient or during the illness of COVID, you need to anticipate for even MI and also pulmonary embolism. Okay.
So the symptoms and signs for pulmonary embolism usually will be vague, but some of the symptoms that patient may present will be pain in cough or thigh, coughing. So they can come with coughing out blood also, dull chest pain, wheezing, loss of consciousness, and shortness of breath. The signs, massive PE usually are fatal, so patient can present with tachypnea, tachycardia, febrile, cyanosis, crepitation, pleural rub, sign and symptoms of DVT, unilateral lower limb swelling, and pain, warm, erythematous. So the Wells score, which is the score that I use to predict pulmonary embolism. So the criteria, such as the previous PE, heart rate more than 100, recent surgery, clinical signs of DVT, alternative diagnosis less likely than PE, hemoptysis, and cancer. So they will give you points. So if the points are 2 or more, which this means that the patient will have a risk for pulmonary embolism. Another score, which is the PERC criteria to rule out pulmonary embolism rule out criteria. So this should be used in a low risk patient. So the criteria is the opposite of Wells score. So for example, the hemoptysis, no estrogen use, no surgery or trauma. And with this criteria, we can use this to rule out pulmonary embolism only in low risk patients. For investigation, there should be no single lab test to diagnose PE. However, you should also take routine laboratory findings to guide you for other differential diagnosis. Next, the arterial blood gas. You can they can result as hypoxia because there's a VQ mismatch, which means there's ventilation, but there will be no perfusion in view of the blood clot, which means no blood flow through the alveoli, so no perfusion occurs lah. So there will be VQ mismatch. The serum troponin levels might guide you in massive PE. However, it is not specific because troponin might also indicates myocardial infarction, and also D-dimer testing. So for D-dimer,
Farah,
yep.
Farah, sorry to interrupt this slides. What you all understand depends on the number, size and location of pulmonary embolism. What is the effect to the patient? This VQ mismatch. Apa maksudnya size, location and number? Apa maksud dia?
The severity?
Yes, how bad the patient is going to present to you. Some patients just come with a complaint of non-specific fever. Katakan patient pregnant 20 minggu. Is a pregnancy is a risk factor?
Yes.
Okay, pregnancy is a risk factor. Came with a complaint of low-grade fever. Persistent dah seminggu. And then she's having on and off difficulty in breathing. So you all thinking is a progress of a pregnancy, right? And then you noted ECG, sinus tachycardia. Temperature 37.2. You dah bagi PCM, you dah bagi drip, tapi the tachycardia is persistent then. So which rule you want to apply now? Your Perk rule or you want to apply your Wells rule?
Sebab patient ada risk kan, doktor. So I use Wells score lah.
Never think about Perk because Perk is in your mind, you're going to, I don't want to see this patient under P. So you think about Wells rule. Okay? So depends on the location and the size, that's how the patient is going to present to you. Kalau major PE, yang saddle shape, yang duduk tengah-tengah kat pulmonary trunk tu, bila nak distribute, yang tu memang clear cut lah. Hang tak payah fikir banyak, it will be very obvious to you. Patient will be unstable, the history also will be very typical, the risk factor also will be menonjol kat depan mata kita. Kalau patient yang memang subtle PE, as the segmental, masa nak dia punya pulmonary trunk nak bercabang, at the trunk nyok kat tepi sana sikit je, she have a minimal non-specific chest pain, pruritic, and then tapi persistent tachycardia. So have a very high risk of a high index of suspicion. Lagi tak buat CTPA, janganlah bagi discharge patient tu. Hang dah bagi PCM, hang dah bagi drip. You do everything in order to reduce the heart rate or in order to improve the oxygenation. It's not improving. Do not take the thing light. Please refer to the primary team for the respective investigation to carry out. Okay? Thank you. Can continue?
The D-dimer lah, doctor. Now, so the D-dimer sensitivity 88 to 97% focal proximal DVT lah, but a negative may not exclude the disease in someone who is at high risk for the disease. We know that D-dimer can be positive in other things also, like endothelial damage, which means a condition that have blood clots lah, D-dimer may increase also. So even though you do D-dimer, it is sensitive, but a negative may not exclude a disease in a high risk patient also.
So sebenarnya jangan bergantung pada D-dimer. That's the final conclusion. Do not depend on D-dimer to make a diagnosis. But if D-dimer negative, you cannot rule out also. True or not? You cannot rule out if the patient have a high risk. It's just a junk. Dia membantu sikit je. Do not put a weightage to your D-dimer. Okay?
So findings in PE in ECG and chest X-ray. So ECG might show you tachycardia, symmetrical T-wave inversion, the S1Q3T3, incomplete or complete RBBB. For chest X-ray, they might show you pulmonary infarction, unilateral basilar atelectasis, Hampton's hum, and watermark sign lah. So ECG, the
previous okay. Bear in mind, Dr. Bila pun dah kerja berapa tahun dah, 11 tahun lah. So I do not have a typical ECG yang menunjukkan this is PE. The common ECG could be a normal sinus tachycardia with non-specific ST changes. That's about 80 to 90% will present like that. Hanya 10% je yang nampak yang Q1, Q3, S1. S1, Q3, T3 ni memang very, very less. So, jangan kita nak cari benda yang nombor 3 tu je. The common is sinus tachycardia. And axis, yes, please give importance to your axis. Ini memang akan menunjukkan kepada right axis deviation. Incomplete or complete RBB. And on the other side, your X-ray, it can be normal. 80 to 90% normal chest X-ray. Hampton House, Western Mark sign, jarang lah kita tengok. Memang jarang. It's about out of 20 or 30 patient, we encountered one patient. Very jarang, okay? So do not concentrate on this. X-ray, most of the time is clear. Your index of suspicion kena tinggi, nah? Okay, next.
Okay, so just to show if a patient presented ada the typical S1Q3, so the S1Q3 and inverted T wave dekat lead 3.
I will be happy if you show me the sinus tachycardia with the right bundle branch block and right axis deviation. That is the most common one. Jangan terikut-ikut dengan S1Q3, T3. Nama je glamour tapi memang tak dapat pun.
Chest X-ray, like Dr. Vilasini said, maybe normal lah, but the Watermark sign, Hampton's Hum, Fleischner's sign tu might also show you pulmonary embolism lah. So Watermark sign, focal pulmonary oligemia, which means there's a collapse of vessel distal to the pulmonary embolism. Hampton's Hum tu the wedge-shaped consolidation. Fleischner's sign, prominent central pulmonary artery, which basically vague lah. Some other pulmonary infection also show this sign.
Senang dah orang dah PE ni dapat infection?
Infection ke? Infection.
Memang akan infak kan? Dia tak ada oksigen. Dia akan matilah tempat tu, infak lah. Senang dapat infection tak?
Infection. Senang
lah. Orang tak ada oksigen. So your bacteria will go sit there nicely or not?
Yes.
So anaerobic will take place. It doesn't require oxygen. Anaerobic will take place, so easily infection will superimpose. So that's where you tend to miss. Okay?
Okay. The echo. So when we do echo, we can note that there's the dilatation of right ventricle. There will be right ventricle hypokinesia, McConnell sign, abnormal interventricular septum motion, and tricuspid regurgitation lah. So macam ni nampak right ventricular hypokinesia with apical sparing, the McConnell sign lah. Yang belah kiri.
You guys can appreciate. Kenapa LV tu tak dikacau, RV yang tengah dikacau? Who can answer to me? Anyone would like to try? Why the strain is on the right side, not on the left side?
Because the left ventricle is more on the anterior part, dia tak kurang involvement dengan lungs.
Salah sayang. Siapa nak tanya? Ashraf? Ashraf?
Ya, dah.
Ya, kenapa ya?
Sebab apa left side tak affected lah tu.
No. You can approach either way. Why right is being damaged or affected more than the left? Left will get affected but not as soon as possible. It's later part. Yang paling awal kena rosak adalah right side. Kena strain, kena hypertrophy, kena kerja keras. It's right side. Why? Isu dia kat mana sekarang sebenarnya dalam pulmonary embolism ni? Dalam jantung kan dalam paru-paru?
Paru-paru.
Yes. So when there is a high pressure in the pulmonary circulation, siapa yang bawa oksigen kepada pulmonary ni? Left side of the heart or right side of the heart?
The right side.
Your pulmonary artery, remember?
Yeah.
Is connected to your lung through your right side of the
Heart.
heart. Okay, when there's increased pressure in your lung, it will cause a backward pressure transmit into the right side of the heart. LV tu sebenarnya dia systemic circulation kan? Right side is pulmonary circulation. So whatever problem in your pulmonary, it will backward to your right side of the heart. Sebenarnya dia punya pressure tu adalah pressure yang tengah build up inside the pulmonary. It takes up the pressure and it is tried to compensate by dilating. At some point it cannot. That's where you started to develop the D shape of your interventricular septum. Maksudnya the pressure inside the right ventricle is too huge. It started to compress your interventricular septum. Okay, bila dia push interventricular septum, dia akan jadikan septum hang flat. Hang punya ventricle LV tu akan jadi macam C. So yang tu jadi, ini nampak tak yang ni D shape. So you will see the D shape of the LV with the dilatation of the RV and positive McConnell sign. Tapi semua ni tak boleh nampak dalam satu image tau. You have to get a different view in your echo probe. Satu, kalau D shape ni, hang kena tengok parasternal long axis. Kalau yang McConnell sign, you have to look in your apical 4-chamber view. Okay? Good. So, PE ni kita boleh diagnose dalam gimana? DED nah. Tak perlu CTP tapi PE yang major lah. PE yang mild, moderate tu memang kena CTP. Massive PE, ultrasound is best tool to indicate. Okay? Gold standard memang CTP lah. Okay.
So ventricular perfusion scans are no longer used lah, largely supplanted by pulmonary angiography, your CT, which will show filling defects within the pulmonary vasculature due to the pulmonary emboli lah, the thrombus in the pulmonary vasculature. So there's a few types of PE. Low risk, non-massive, submassive and massive PE. So we'll focus on the bottom two, submassive and massive PE, because a patient usually comes with unstable, and the management are also different from the top two PE lah. So the treatment options: anticoagulation, your heparin, low molecular weight heparin and unfractionated, and thrombolysis, IVC filter and embolectomy. So this is the algorithm. So when patient first came in with pulmonary embolism, hemodynamically unstable, you should stabilize patient first, and note whether the patient are contraindicated for anticoagulation or not. So if yes, to evaluate whether PE confirmed or not, and then we'll look at whether patient needed for thrombolytic therapy, indicated or not, and if yes, whether they need for surgical or catheter embolectomy lah, if the thrombolytic therapy is contraindicated. So the emergency management, your airway breathing and circulation, your hemodynamic support for patient, oxygen supplement, you can give patient high flow oxygen up to, if patient needed for intubation, you may proceed so. IV fluid and inotropic support if patient in shock lah. But if diagnosis of PE is already confirmed, then you should start heparin lah. So from my readings, fluid also should be used with extreme caution, because we already know when PE, there's a right ventricular dysfunction already. So when we give aggressive fluid resuscitation, the right ventricular wall will be more stressed and will cause more ischemia to the right ventricular and cause further interventricular subtle shift towards the left ventricle and will worsen the left ventricle compliance and filling. So the most common initial approach is 1 pint to 2 pint normal saline rapid administration lah to resusc patient. And also the oxygenation, usually try to avoid intubation, because we decrease the preload to right ventricle because of the transition from negative pressure ventilation to the positive pressure ventilation, and will increase the interthoracic pressure. So other option can include high flow nasal cannula or BiPAP or CPAP. But then if patients still cannot tolerate BiPAP or CPAP, then may proceed with intubation also. So anticoagulation, your low molecular weight heparin and unfractionated heparin. So usually the low molecular weight heparin lah, the enoxaparin given subcutaneously, and heparin unfractionated when patient is less stable. So the thrombolytic therapy reserved in massive acute PE when patient is unstable and there is no contraindication, which means patient have no bleeding tendency lah. Streptokinase, urokinase and RTPA, but usually the streptokinase lah is what we use with the following dose. But there's absolute contraindication for it: intracranial neoplasm, recent surgery, intracranial or spinal, history of hemorrhagic stroke, active bleeding within the previous 3 months. So what are the options for these patients?
Yep. We do have other agent, also thrombolytic agent in our hospital, which is Altiplase, but we reserve for those who are pregnant with the PE.
Okay. So for this patient, we have to expedite the diagnostic evaluation so that they can go for the alternative therapies such as the IVC filter and embolectomy. But this is also should be assessed with physician lah. And next, the complication: pulmonary embolism, acute and chronic complication, cardiac arrest, pulmonary infarction, hemoptysis, pneumonia, chronic complication, chronic breathlessness, and pulmonary hypertension. So that's all.
Okay, in summary, take home message untuk PE apa ya, Farah?
Take home message: we should have suspicion for pulmonary embolism in patient that have
high index suspicion.
High index suspicion.
Apa jadi OCD pun tak apa untuk Dr. Vila. Pasien tadi kardiak je nak suspect PE tak apa. I don't mind. But you need to have a high risk of suspicion. Kalau kita miss, it's going to be fatal for the patient. Okay?
Yeah, because they come with very vague sign and symptoms.
Very vague, yes. So, one is high index of suspicion. Lagi?
Dimer not can help a bit lah in the investigation.
It can facilitate, but it's not a definitive investigation. So tak payahlah ambil di demo untuk semua pesakit yang orang suspect PE Okay, lagi? Pasien yang dah ada DVT datang dengan SOB, nak ambil di demo. Known case of DVT on heparin on warfarin at home came back with sudden onset of SOB with a heart rate of 140. Ambil dah di demo.
Taklah, dah memang DVT kan?
DVT kan? So nak buat apa nak ambil? It's known case. I know it will be raised. So it's not going to help to narrow my diagnosis. Now I need is all about CTPA. But if the patient is unstable, my echo can help out to check whether the patient fall into submassive ataupun massive. So take home message: high index of suspicion. Kindly give weightage for all the risk factor for PE and DVT. Do apply well score and PERC rule respectively in order to include and exclude the diagnosis. Early involvement multidisciplinary team in order to achieve a good outcome for the PE patient. And then also prophylaxis of anticoagulant is recommended for those patients who are suspected for PE. Contoh doktor bagi, katakanlah salah seorang you dapat ian atau sick atau kolanera ataupun Greek hospital, you suspect the patient is having a PE. Based on your risk factor, clinical presentation, but you do not have an ultrasound, you do not have a TPA, you start the patient on anticoagulant. Okay, because if you can't explain why the patient is hypoxia, there's no obvious reason, you may start the patient on anticoagulant as a prophylactic dose. Bukan treatment dose, prophylaxis dose. And you transfer the patient to the respective. Okay?
Okay.
Okay, thank you everyone.
Thank you, doctor.
Good job. Good presentation, both of you.
Okay.
Okay.
See you all then.
Thank you.
Ya,
Thank you, Dr. Fairuz.
Thank you, Dr. Ila. Okay.
Okay, Dr.
Okay,
Virus.
thank you.